Stroke is not a monolithic diagnosis. It is a spectrum of vascular catastrophes. In a 2,000-bed hospital, we don't just treat stroke, we manage a symphony of variables. Every second, 32,000 neurons die, but complexity is the enemy of speed. Multiple services, frantic handoffs, and high-risk drug decisions create a Swiss cheese model of potential failure. This is why the pharmacist exists here, not as a consultant in a basement office, but as a core decision-maker at the bedside. In this arena, we don't just verify orders, we prevent disasters. Large hospitals move in parallel. While the neurologist assesses the brain and radiology preps the CT, the pharmacist manages medication reality. Before the team even asks, the pharmacist has the drug narrative ready. We aren't looking for allergies, we are hunting for anticoagulants. The big four: warfarin, apixaban, rivaroxaban, dabigatran. The crucial questions: last dose, renal clearance, adherence. This isn't secondhand information. We are physically or virtually present during the activation. We hear the last known well time directly from the family. No delay, no interpretation errors. Thrombolytics are the most unforgiving drugs in the pharmacopoeia. There is zero room for error. The pharmacist acts as the final safety gate. We confirm inclusion-exclusion criteria, not just checking boxes, but questioning clinical nuances. The weight trap. Estimated weights are dangerous. We demand an actual or bed scale weight. The calculation. 0.9 milligrams per kilogram IV or the 0.25 milligrams per kilogram bolus. We calculate, we double check, and often we prepare. By owning the preparation, we ensure the bolus to drip transition is seamless. This is how we keep the door to needle time under 30 minutes while keeping the intracranial hemorrhage rate at a minimum. Sometimes the stroke is the bleed, or the patient arrives on a direct oral anticoagulant and needs urgent intervention. Reversal is a high-stakes chess match. The pharmacist identifies the agent, the dose fixed versus weight-based for PCC, and monitors the labs. As the patient moves to mechanical thrombectomy, the pharmacist shifts focus to hemodynamics. In the angio suite, low pressure kills the penumbra. We manage the vasopressors and the anesthetic agents, anticipating the post-procedure reperfusion injury before the patient even hits the ICU. In the ICU, we move from minutes to hours. Cerebral edema. We aren't just giving mannitol, we are managing the osmolar gap and sodium targets. Seizure prophylaxis. We evaluate the cortical involvement. Does this patient actually need levetiracetam, or are we just adding side effects? Regarding sedation, we advocate for light sedation. If the patient is too sedated, the neurologist can't see the decline. We manage the neuro-awakening. Survival is only the beginning. Secondary prevention is where the pharmacist builds the wall of protection. Regarding antiplatelets, we individualize. High-risk TIA, we start the dual antiplatelet therapy clock. Regarding statins, higher intensity is the rule, but we monitor the statin-associated muscle symptoms to ensure long-term adherence. The transition, this is where patients are lost, we lead the reconciliation. We eliminate the autopilot orders that no longer serve the patient. Fear is the silent comorbid condition of stroke. Explain why a blood thinner is different from a clot buster. We don't sugarcoat side effects, we empower the patient to recognize red flags. In a large hospital, our role extends to the next generation. We analyze the door-to-needle data. We run the trials. We don't just follow the guidelines, we help write them. The future of stroke pharmacy is prescriptive authority and AI-driven precision dosing. But the human judgment, the ability to look at a crashing patient and make a call, remains irreplaceable. In a 2,000-bed center, we are not optional. We save time, we save lives, we save brains. If this session challenged your perspective on the clinical pharmacist's role, like this video and share it with your multidisciplinary team. Subscribe for more deep dives from the front lines of critical care. Because in the world of stroke, education is the best medicine. Thanks for watching. I will see you in the next video.